COVID-19 crisis and beyond. We don't have all the answers to preventing COVID infection. We don't have all the answers to treating COVID infections. And so to some extent, this might be a little premature, but it was very important to us to begin a public dialogue about lessons that we've learned over the course of the last 6 months addressing the COVID-19 crisis with the population that we are all concerned about, people who are experiencing homelessness in New York City. We are very lucky this morning to have with us as our keynote speaker who will introduce the topic, Dr. Fabienne Laraque, who is the medical director of the Department of Homeless Services. COVID-19 has exposed disparities in healthcare quality and access that we're all very familiar with, but it has also demonstrated to us the importance of very strong public health leadership. For the last 6 months, Dr. Laraque has done an extraordinary job working with all of us to make certain that we're keeping the people who we serve as safe as possible. This has been a period of time, if we can be frank, where we've lost, I think, a little bit of confidence in our government leadership. But quite the opposite has been true with Dr. Laraque. She has been an outstanding leader through the last 6 months. We at Care for the Homeless and many of our colleague agencies have worked closely with her. And we're very grateful for all of the leadership that she has shown. And in fact, the outcomes really tell the tale, because the rate of infection and the rate of mortality amongst homeless people in New York City has largely tracked the general population. Considering what we were afraid of at the beginning of the epidemic, this is an extraordinary achievement. We shouldn't be surprised, of course, because Dr. Laraque has a long history of addressing epidemics. She's been one of the city's leaders in the fight against hepatitis B and C, and of course, she did outstanding work during the HIV crisis in New York City. So she was well prepared for this and helped us learn from those previous epidemics in terms of what works and what doesn't work in New York City. So I am very delighted to welcome you all here today, and I'm delighted to introduce Dr. Fabienne Laraque, and as part of my introduction, to thank her for all of the outstanding work that she has done. Dr. Laraque?
Thank you, George. This was a delightful and incredibly welcome introduction. I want to thank Care for the Homeless for the work that you do every day for our population over essentially decades of work, and also for inviting me to share our experience during this webinar. So I'm going to start by giving you context of where the COVID pandemic arrived in our population. So the sheer size of the shelter system in New York City makes healthcare delivery in general extremely complex. In any given day, there are about 50,000 homeless person experiencing homelessness who sleep in a shelter bed, and an estimated 3,588 person experiencing homelessness. Of sheltered client, about 60% are family with children. We have about 18,000 children in the shelter system on any given day, and a third are single adults, with another about 5,000 in adult families. In a given year, we serve over 130,000 homeless individuals in our service at DHS. That's larger than many cities in Connecticut, for example. To serve our population, we oversee and fund over 400 shelters and street sites, including about 150 single adult shelters, 170 to 100, about 170 family with children sites, 20 shelters for adult families, about 25 safe haven for a person experiencing street homelessness. We are open 24/7, 365 days a year. We never stop. Single adult shelters are congregate setting with small to large dormitories, shared bathroom, shared cafeteria, and as you can imagine, that poses a risk of transmission of infectious diseases, while families are in their separate unit. While, just for again historical context, while the congregate setting traditionally lend themselves to transmission of infectious disease. We haven't had an outbreak of tuberculosis in years and years. We barely have maybe half a dozen cases a year. We don't have outbreak of influenza. We haven't had outbreak of foodborne disease. We really haven't had much transmission of infectious disease in the shelter system. And as George mentioned, we saw that our response to COVID has been actually quite successful. In addition to the physical context, our population entered the shelter system with a high rate of chronic and behavioral health conditions. Overall, 62%, two-thirds have either medical or behavioral health conditions, with 41% having at least one medical condition and a third having a behavioral health condition. Among single adults, these rates are much higher. 3/4 of single adults have either medical, mental health, or substance use condition, with almost half presenting with at least one chronic medical condition, 40% with a mental health condition, and 35% for substance use issues. Adult families, and especially families with children, have a lot lower rate of chronic and medical conditions than single adults. Among adults living in shelter, the top medical conditions were asthma, hypertension, and diabetes, while children had a high rate of asthma. Of course, many of these conditions put one at risk for complication from COVID-19. In terms of behavioral health condition, among adults, you see depression, anxiety, bipolar disorder, and among children, autism and other developmental disorders. While unfortunately deaths have been increasing a bit among the adult shelter population, we have very, very few deaths among children, thankfully, in the shelter system. And in terms of the cause of death, the number one cause of death up to this year among both shelters and non-shelters, they said that the leading cause of death were drug-related, mainly accidental overdose, followed for sheltered residents by heart disease, cancer, diabetes, and among non-sheltered residents, drug-related, alcohol dependence, heart disease, and accidents. So you can see that COVID-19 arrived against a backdrop of clients with multiple medical and behavioral conditions and many vulnerability related to their negative social determinant of health. So in addition to challenges inherent to the shelter system and vulnerable population, COVID created additional challenges. Obviously, it's a disease that is transmitted via droplet, perhaps via the air. It's relatively easily transmitted. It's more complicated than the flu and many other respiratory disease. But in addition, we experience other challenges. At some point, we were hoping to be able to mandate COVID testing. We were able to mandate isolation in quarantine. Unfortunately, we were not allowed, and it wasn't possible, I should say, to mandate any of those activities. So we had to use system changes in awareness and education to promote isolation, quarantine, and testing. Asymptomatic transmission, like everywhere else, poses a challenge before the advent of routine testing. The initial lack of testing, the long turnaround time, the initial lack of personal protective equipment, like in the rest of the city, in the rest of the world, in the rest of the country, I should say, presented challenges for us. In addition, of our 100 of shelters, clinical services exist on site only at a few sites. So how did DHS address these challenges? I mean, our entire department mobilized in a really extraordinary way. I mean, I really thank George for complimenting my contribution, but it would not be fair to not mention the contribution of our capacity building team or program team. We mobilized in a really unprecedented way, and I'm extremely proud to have been part of working at DHS during this time. How did we address those challenges in the COVID pandemic? Again, on multiple fronts, including early and regular communication. We started our communication early March, even before the city closed, even before a pandemic was called, with information on symptoms and case identification, on infection control and physical distancing, cleaning and infection control guidance. And by April, we were disseminating guidance for sites that had 3 or more cases to avoid transmission. We provided PPE initially as a targeted distribution where the supply was very low, and now we are providing monthly supply to all the sites and the on-site clinic, including N95 masks, surgical masks, gloves, gowns, etc. We started COVID-19 symptom screening initially with linkage to care and hospital referral where needed. We established at all sites standard screening with access to colleagues at the New York City Health and Hospital 24-hour hotline for help with clinical consultation at site where clinics were not available. We expanded one of our serious incident hotline to a 24/7 COVID-19 hotline that all shelters, all site, and all hospital could call for referral. That was a pretty extraordinary feat to step up that hotline pretty significantly. We modified our service protocol. We limited the need for families to present in person at our family intake center. We started a virtual walkthrough for appointment viewing. We collaborated with the State Office of Alcohol and Substance Use Services and the Department of Health for methadone delivery at isolation site to help clients not having to go to their methadone treatment program. We expedited intake process for clients directly from the subway system. We opened our first isolation site in the middle of March with 20 beds. Again, the site was open in a week. And rapidly within the next couple of weeks, we opened 4 more isolation sites with up to 700 beds. That was a lifesaver for our shelters and for our hospital. We were really looking for discharge rapidly our client that had mild, moderate symptoms and could be discharged. The sites provided nursing oversight 24/7 with clinical check and a standard discharge process that our medical office reviewed every single the discharge from isolation to ensure that no one who was infectious was sent back to shelter. And the placement into isolation site was done through this 24-hour hotline and via standard screening question to prevent us from isolating individuals that were too sick to be in isolation hotel. In late April, again with Care for the Homeless partners, we started proactive COVID testing at one of their shelters in the last days of April. That was highly successful. We were really, really hopeful that we were going to continue to have this 80–90% response rate that shelter had. And we started throughout the month of May and June proactive standard COVID testing, high scale testing at all the shelter that had on-site clinics. And ultimately we were able to increase testing capacity by contracting with 2 clinical providers that solely do testing. Right now we are able to test 10 sites, 10 shelter and street sites per day since late June. We have tested thousands and thousands of clients, and we are able to retest every 4 weeks. We are providing routine testing at our adult intake sites 7 days a week for about 12 hours a day. We strategically were able to relocate clients out of congregate shelter to detensification hotels, and that was one of the really a feat of management and ingenuity that our capacity building and program partners, my colleague at DHS have been able to do. We normally it takes months to negotiate a new shelter, a new site, and move and create a new shelter. But shelter were moved into hotel within essentially a week. The month-long system was packaged into a week, and we were able to move thousands and thousands of clients from congregate setting into single, double room hotel. The shelter were either relocated fully into a hotel or partially into a hotel, and some large providers opted to move multiple shelters into a common large hotel. We increased placement option for clients experiencing unsheltered homelessness, and we have a robust data tracking. Our data team in the medical office has been tracking since the beginning of the epidemic and through the response, cases, death, test, time in isolation, client characteristic, using a flexible electronic app and for real-time monitoring, allowing us to use data for case identification, identifying site with 3 or more cases, prioritize testing, and contact investigation, and provide reports to a host of areas that needed reporting. Despite all this challenge and despite the complexity of COVID, as of August 13, we had a little less than 1,500 confirmed, tested positive COVID cases and 100 confirmed deaths. The majority of cases and deaths were among single adults. With proactive COVID testing as of September 14, we've tested almost 16,000 clients. And we, since then, we are offering testing every 4 weeks. In wave 1 of our proactive testing, which started slowly and went from May to the middle of July before we were able to establish this 4-week testing, the overall positivity rate was 3.6%. It was higher in May and it steadily decreased over the course of the spring and summer. The positivity rate in wave 2, we spent most of the late July to the middle of August, was 0.3%. And in wave 3 on the way, so far we haven't had a positive cases. We've started COVID testing at intake, at single adult intake since early August. We've tested over 1,600 new clients so far, with only 9 found positive, or a positivity rate of 0.6%. So yes, we've had great success, but of course we have many gaps in need. Again, as I mentioned before, out of almost 400 shelters, only about 70 or so have medical or mental health presence on site. A few more have a nurse on site, and therefore most shelters do not have direct access to clinical care. And although we've been able to somewhat contain the COVID epidemic impact in the shelter system, our clients still have high rate of heart disease, hypertension, cancer, and behavioral health conditions that put them at risk for poor health outcome. So with this lack of on-site services, lack of standard services, skill level, hours, and volume of operation, even at site with clinic, that also creates difficulties. Many clinical sites are funded by DHS. Funding is often low. Many clinics operate only a couple of days a week, and some are not Article 28 licensed, like Care for the Homeless, and therefore they cannot bill for service, and therefore they cannot expand. Services that are really, really important for clients with high vulnerability, such as medical care condition, health promotion, medication adherence support, all those wraparound services that, as George mentioned, have been really successful in the past when I've worked in HIV and hepatitis program, are essentially non-existent on site for DHS clients. And again, based on my experience, these wraparound services are key for this vulnerable population with multiple chronic medical and mental health conditions. In addition, some preliminary analysis of medical claims data show that a significant portion of DHS clients who use acute care services, whether emergency department or inpatient, also access primary care and are even enrolled in care management services. So something is clearly not working. In addition, our analysis also show that our clients are not necessarily accessing even medical care on site just because they are available to them. So what's wrong in these pictures? So we we see that clearly simple access, physical access to care is not sufficient, whether on site or in the community. Primary care without wraparound services is insufficient for our population. Why could that be? Well, health is not their priority. Housing is. It's also not clear that the care that is available in the community is always attentive, targeted, sensitive, and culturally appropriate. We only have about a dozen homeless healthcare providers that are attentive, sensitive, and culturally appropriate, and there's not enough of those, and not enough in the shelter system. Many of our clients are using acute care service because it's easier to them, and because they also have multiple comorbid conditions. They have medical, mental health issues, they have alcohol use disorders, complicated combination that really put them at high risk of visiting the emergency department. What do we need? I'm sure this panel is going to expand on some of those ideas, but I think we need studies to evaluate what can help improve access to and mostly utilization of care. We have access, we need more utilization of care. Access to housing, solid and standard and intensive wraparound services, including health promotion, incentive, navigation of the healthcare system. Wraparound services to some extent in shelters, tight linkages with medical providers in the shelters nearby communities, medication-assisted treatment for opioid use disorders, as well as alcohol use disorders. Both are underutilized in general. Improved use of technology may also help and should be tested. Use of phone services, text, telehealth. COVID epidemic had opened the door to more telehealth services, and we are all hoping that that will really continue to improve access. Just like it takes a village to raise a child, it will take a city, our entire city, to improve the health of person experiencing homelessness. With that, I think there is time for questions, and thank you for your attention.
Thank you, Dr. Laraque. We appreciate those comments, and particularly your analysis of the gaps in access to quality care that homeless people have always experienced. COVID cannot, it's a great learning opportunity. It has exposed some of the fractures in our system, but we also can't return to normal because normal wasn't very good. So part of the purpose of this panel this morning is to evaluate some of the things we put into place at Care for the Homeless during the COVID crisis, and to begin to look forward to what healthcare for homeless and unstably housed people will look like going into the future. I'm very pleased to introduce our panel moderator, Dr. Regina Olasin. We've all experienced many different types of anxiety over the course of the COVID crisis, but one of the things that made my life so much easier is knowing that Dr. Olasin was our chief medical officer, and her calm and competent leadership really made a huge difference in our ability to respond to the crisis. We didn't lay off a single staff person. We didn't furlough a single staff person. We remained accessible and available to our patients throughout the crisis, and that made an enormous difference. One housekeeping point I'd like to make is that we're asking folks to hold their questions for the end of the panel. We will leave time for that, and to use the Q&A function, not the chat function of the Zoom platform. So please use the Q&A function to submit questions. It is now my great privilege to introduce Dr. Regina Olasin.
Thank you, George, and thank you, Dr. Laraque, for a terrific overview and perspective of what we've all been experiencing together over the past 7 months, really. I'd like to again welcome everyone who's joined us, and before we move into the panel discussion, there's going to be a brief poll just asking who is participating on the webinar, so that there'll be a question flashed up on the screen. If you can answer it, then we'll proceed to the panel introductions.
And Dr. Olson, we'll put up the poll right now. I do have 2 questions, and Dr. Laraque did offer to answer a couple of questions. I do have one that says, do you have numbers on staff positivity rates?
So we don't systematically test all the staff. Okay, let me take this back. We know we are sometimes alerted when staff have had COVID and are positive, but we don't, it's not reportable in a similar way as clients. We don't isolate staff. Staff are advised to isolate at home. So there is no way to really calculate a true positivity rate for staff. In our proactive testing, we also offer testing to staff, but we don't know, we don't again calculate, it's not mandatory, and we don't calculate positivity rate for staff. So while we offer the test, we really don't have those rates.
Thank you. And then one more question is, what detox options are available to homeless New York City clients who are not living in shelters?
So that's really not a question for me. I don't oversee detox. I do know that OISLAS funds a number of detox, and some hospitals have them. However, detox is not really very effective in managing substance use disorder. So we advocate harm reduction and medication assisted treatment. But I'm sorry, I can't really speak to detox. That's not in my area of expertise.
No problem. Thank you so much, Dr. Laraque. So these are the results, Dr. Olson. Looks like we have a pretty good mix. Most homeless service providers, healthcare providers, and shelter providers are at the top. I'm gonna stop this and we can move forward.
Thank you, Natalie. So I'm really delighted to have the opportunity to introduce our panel, many all of whom are frontline providers at Care for the Homeless in our multiple federally qualified health center sites. Luis Fernandez is a certified alcohol and substance abuse counselor at CASAC. And he works in the Bronx and at multiple facilities, also with the street outreach teams. Nora Leuth, family nurse practitioner, who's been extremely instrumental in providing services in Brooklyn and Queens and really has spearheaded a lot of the virtual access telemedicine conversion that was necessary in our ability to provide care during the most critical times in April and May particularly. EJ Bryant-Mazauskas, who is a resident of Susan's Place, who can provide really very unique insight as to how this had impacted some shelter residents. Dr. Henrietta Okpala, doctor of nursing practice and psychiatric mental health nurse practitioner, who's been again providing services in our Brooklyn and Queens area and extensive telemedicine access for the population, many of whom have been relocated to facilities in Manhattan. And Simone Thompson, Care for the Homeless Director of Shelter Services, who has worked very closely with the health centers as well as Department of Homeless Services during this period of time in keeping the continuum of care and communication and access to care for our shelter residents at Susan's Place and 52nd Street. So welcome to the panel, everyone. We're going to sort of, I think a good segue might be the question that was asked Dr. Laraque, and Luis, maybe you could offer some insight about some of the services in the community and to some extent, you know, what your perspective has been during the COVID epidemic with the street outreach and the availability of services for individuals with opioid use disorder. Has there been an increased need? What have you seen?
Good morning, everybody, everyone. Well, basically the whole substance abuse services throughout the period of March and April, it was something that nobody, with the COVID, nobody expected. However, we did get an increase in, I mean, it went beyond the drug use that the clients demonstrated. And basically it was a lot of, excuse me, it was a lot of methadone that were being used and alcohol. The street outreach, we were able to continue to go out throughout the course of March and April, because at that time, like at the beginning of March, we really didn't know. We were still waiting for the city to close up, or they were going to close, shut everything down. When they did, we did stop going out, you know, until about May. But in the interim, we were able to provide KSAC services and also the Suboxone program, which we have about 135 to 140 clients. We were able to provide them with the Suboxone prescriptions through our doctors that we have with Care for the Homeless. And we were able to give them enough for them to have for a month or so. And also, we were, I was able to make a lot of follow-ups, you know, with them on the phones. Unfortunately, there was a lot of them that, as everybody knows, there was a lot of individuals, homeless, that don't have a phone. So that's where the outreach came into play, and we were very instrumental in reaching out to a lot of the clients, because a lot of, I could say 100%, all of them were very scared. They didn't know where the medication was coming from. They didn't know where the service was coming from. And thankfully, we had, our agency had, the support that the clients needed. And once I basically let them know that everything was going to be fine, and also that they didn't have to, some of them that were in shared rooms and safe havens, that they didn't have to come out, that their prescriptions was going to be sent to the drugstore. The only challenge was clients were a little bit hesitant about going to pick up their medication. And thankfully, we do have pharmacies that will be able to make deliveries.
Thank you. Would you say that during this period of time, Luis, that there's been an increase in overdoses, or is there any concern over access for patients who had been in methadone clinics to receive their medications?
Yes. So the overdose, fortunately, and we as in Care for the Homeless, we did not see a lot of basically one or two overdoses that I heard of, but they were able to, the results were positive. Now, there was a lot of clients the clients that were going to methadone programs, they were able to get their methadone for, let's say they will give them take home for a week, 2 weeks, a month, so they won't have to be going to the program. One of the challenges that we did have, our clients started drinking a lot of, started drinking methadone because methadone was readily available in the streets, and we're still having to address those challenges with our clients that were, it got so easy that anyone could just buy a bottle of methadone in the streets. Like I said before, there was a lot of alcohol that was being done. Also, the people work, with inside, indoors. Most of our clients were in safe havens and rooms, and basically everybody was very focused on what was going on, and people started drinking a lot. And like I said before, they were using a lot of drugs. So now we are having this challenge of addressing these needs. And also, one thing I must add about detox, in those days, March and April and May, we cannot get a lot of the clients into detox because the detox wards were being used for isolation. The beds were being used for isolation. So it was hard. So we were able to manage, as best as we could. And now we are actually addressing most of the challenges that we did have with the drug use. And I could say that unfortunately, there were some clients that just left our clinic. We had to discharge some of them, but some of them just decided not to come back, unfortunately. But with the outreach team that we do have, with the support that we do have, I am hopeful that we will be able to get these clients back. Most of the clients, Suboxone clients, mostly, sometimes we don't see them for a couple of months because they are in the streets, using, but they usually know where we at, and we have had a good turnaround of clients that left and then came back.
Thank you. Nora, you do Suboxone treatment in an ambulatory setting. Had you seen any changes during this period of time in interest?
Yeah, I just want to echo what Luis said. Most patients are really receptive to telemedicine for Suboxone. They really were happy that they were able to do their Suboxone follow-up visits over the phone. And yeah, it just was very easy and convenient for them, and they were able to stay safe in their homes and get their medication. Anytime, I still do some televisits over for Suboxone, and anytime I talk to our clients, they're thrilled to talk to me. They're like, I'm so happy to hear from you. And then usually everyone's pretty much doing well on their medication. And yeah, everyone's been really receptive to the telemedicine piece for Suboxone, and they're thankful that they can still receive their medications and still do televisits with us.
And maybe we could move into some of your experience with really everyone's receptivity to using telephone and telemedicine in a primary care setting.
Absolutely. So someone mentioned, I think it was Leuth again, who the biggest issue is a lot of our clients do not have phones, but I'll focus on the piece for when they do have phones, they are really, really receptive to phone visits. I've been lucky to be able to follow up with a lot of people with chronic illnesses, with blood pressure management, diabetes management, because during basically March through July, it was really hard for people to come into the clinics, and they were scared, especially if you have chronic illnesses like diabetes, hypertension, they're extra scared. But in the meantime, they're like, I want to follow up with my diabetes. I want to make sure my blood pressure is controlled. So I've been able to send a lot of blood pressure cuffs to their house, a lot of glucometers, make sure they have a working glucometer, make sure they have all their supplies. So we talk about their blood sugar logs for the past few weeks. How's the diabetes been? We talk about their diet, talk about how they can get some exercise during the COVID times. I read through their blood pressure logs with them. How's their blood pressure been? What kind of things can we do to make it better? Just kind of working with patients over the phone has been really helpful, I think, hopefully for them as well. And for me as a provider, it's really nice to just be able to like informally kind of check in with everybody, see how it's going, see what we can think of together of ways that they can manage these chronic illnesses without risking some of their safety concerns by coming to the office.
Have you seen any overt misunderstanding about COVID or concerns about not wanting to come into the office because of exposure in the patient population?
Yeah, so I definitely in the beginning, it was really obviously March and April were high intensity times for everybody. So most people were really concerned at that time. Now I would say about 95% of my patients do not have any issues with coming into the office for routine visits. I will say that if something can be done over the phone, we try to do it over the phone. If a person who's diabetic comes in for a lab test, their follow-up usually is over the phone. We can talk about what their diabetes numbers look like in their lab work, any other lab concerns I have, kind of what our medication management plan is. But I would say about 95% of my patients are, at this point in time, receptive to coming into the office.
That's very good. Have you had issues about vaccine hesitancy in the COVID era, or concerns that way from any of the families?
I would say the opposite. They all are like, oh, I know my child is due for vaccines. He's been due since March. We've been trying to get him in. So most parents are really like pushing to have these preventative well-child visits. And that's been great.
Yeah, and you certainly had an excellent response to the initiatives in Brooklyn that you've been part of. Thank you. Any other thoughts about the overall transition and from a provider perspective, how things could be done going forward?
I just think that as a person who works with mostly young adults and children and a lot of preventative medicine, I think the ultimate battle between like, is preventative healthcare worth the risk of COVID, risking yourself to COVID exposure? And personally, I'm biased, but I think yes, getting kids up to date with their vaccines, getting preventative health screenings, cancer rates aren't going to change because of COVID. So being aggressive with preventative medicine and not having people fall behind, I think is really important.
Thank you. We are also fortunate to have EJ, Bryant-Mazauskas, and EJ has been on the receiving end, having been in a shelter during this period of time and experienced this pandemic somewhat differently in terms of how the structure of services needed to be modified. EJ, could you share what you see as having been the impact that COVID had on your experience during this past 6 months?
Well, I'd like to begin with saying first that the medical care that I've received in the system, and I'm considered one of the more fragile occupants because of my age. I'll be 81 in December, and I have a number of, or several underlying morbidities. The care has been excellent. What I have found is that there's a tendency, not a tendency, I feel that I'm working with the medical team as opposed to having things done to me, and that makes a big difference to me given my background. I was one of the early people in the shelter to be infected, so a lot of things that are being addressed now weren't there at the time, so I don't know if it would be helpful to repeat them, with the exception of the fact that the things that I saw that could be addressed to improve the delivery of care now and in the future had to do with basically with communication and monitoring. When I was put into isolation twice, and that was the result of a lack of communication or someone to monitor how things were going in the isolation hotels. It was very successful with regard to the health department calling and the nurses calling and what have you. But what was missing from that was, for me anyway, was input from the client that things were going based upon a pro forma issue where 14 days in, then you were passed along, you were going back to your shelter. I wound up, because of whatever reasons, being in isolation the first time for over 5 weeks. Now that doesn't fit into the way things were normally handled, but what it did do, for me anyway, was to expose the fact that it would really be helpful to have input from the client. If I say, gee, I'm really not feeling well, I really need to be tested, and I'm sent back to the shelter without having been tested, that's a lost opportunity, I think, to have that input that tells you, well, not everyone's going to fit into this, and maybe we should look at how we can make the system more flexible, more nimble in terms of responding to those people who are outliers. But anyway, that I think would be the most important thing that I could offer at this point. A number of the things that are of concern that I've heard from other residents have already been spoken to. Recently, I had several conversations with people in the shelter who said they were really concerned about being reinfected. And I think maybe having some way of talking to people about that, or acknowledging that, yes, you know, this may be a concern on your part and we understand it, but, you know, proceeding from there. I would think that's, oh yes, very important, very important. Okay, specifically with regard to my particular case and the quality of care that I've received. There is an acknowledgement on the part of medical staff that this virus, as they say, is novel, whatever, or this is something new. And one of the things that it's, as I understand it, that's been determined is that it's an infectious vasculitis, which means that one, people are going to respond differently because we're all put together very differently. And two, you have the possibility of a number of your systems, your medical systems, being affected. So everything that could possibly have been affected by the virus is being addressed by the medical team. I'm going through a series of visits to specialists because some of my original issues have been exacerbated, and I cannot tell you how comforting that is.
Do you, would you say that your access to your medical provider was available to you during the period of time that you were in isolation? Was there communication between
absolutely. Absolutely. I received my I was just about daily, really. Actually, yeah, daily. I was in contact with someone who, excuse me, with my nurse practitioner, uh, who kept regular contact with me.
And I mean, that's I think that's very good to hear in terms of communication. Would you say that the access and the communication was enhanced by virtue of there being an on-site health center at the shelter? At
Susan's place, the shelter you're talking about, not in isolation, but
not in isolation, but yeah, at the
oh
shelter.
yeah, absolutely, absolutely. I think it's really unfortunate that that doesn't exist in each shelter or something very close. You know, maybe it makes a big difference.
And the relocation, having been relocated from Susan's place for a period of time, how has that experience been different from the isolation relocation?
I'm sorry, could you repeat? I'm not sure I followed the question. Say again.
So how has your experience been having been
Oh,
in
I hear it now.
one of the hotel facilities as compared with the isolation experience?
Right, I'm sorry, I'm a little slow. I didn't have much sleep last night. Like night and day, really, in the sense of the quality of care that I'm receiving. And here I'm talking about within the shelter system, the medical, whatever. In isolation, for me, there were a number of problems. And those things had to do with whoever was being contracted to run the programs there. In the hotels, in the hotel where I am, it's very clear that this is something that's under the authority of Care for the Homeless, because it's, as I said, it was like night and day. It was taken into account, just a couple of specifics. Again, as I said, I'll be 81 in December, and there are a number of floors in the hotel where I am. I was put on the second floor. In addition, I was given a room by myself, and I'm assuming that that was taking into account that I had been infected already. So, and it's also located on the floor in a place that's very much separated from the others. So, you know, what more could I ask, right?
Well, that's very good feedback. Thank you. I think actually it leads into Simone Thompson, who has been intimately involved day and night with.
Oh, and I'm sorry not to interrupt you, but she was very specifically involved in a particular problem that I ran into in isolation. So yes, I'm sorry. Go ahead.
No. It's important to hear that. But Simone, your staff and your involvement has been overwhelmingly impressive during this period of time, and I would wonder if you could offer a perspective on whether having had the on-site health center made a difference in both the isolation movement initially and then the relocation that occurred after that. Was it a benefit or an obstacle to care?
In the very beginning, when this first started to come out, I think one of the benefits we had was the on-site health center, because anyone who had a symptom was able to get an immediate evaluation. So Susan's place has 200 women living here, and you know, we have a lot of clients who have chronic medical issues, and so having a nurse or a doctor on site to evaluate concerns as it related to COVID was really important. So we were able to move a lot of clients quickly out of the general population into an isolation room until we were able to relocate them to an isolation hotel. Again, in that very beginning stages, we didn't know if the person was necessarily COVID positive, but it was a precaution that was recommended by the medical providers, which was very useful in containing those who may have been COVID positive, and to protect the others that were in the large rooms that have multiple residents in them. I would say the same is true in the hotels. In the hotels, we have at 52nd Street, we have medical providers on site, and we also have Susan's Place Health Center still operating that could see any clients that we have who have any medical needs. So having the health centers on site has been really very important and also for one of the things that I think was very positive, though telemedicine was used a lot, most of our clients also were willing to come to the health center because it's someplace they were familiar with. And the shelter being empty and Susan's Place Health Center being on site where the shelter was, there's plenty of room for isolation if anyone came here wanting to meet with a provider. So I think it's been a benefit having the health center on site.
Did you notice any service gaps during this period of time that were brought to your attention by any of the residents as they were relocated or otherwise?
I would say some of what Lewis mentioned earlier in the beginning, because we were all learning about this together. I think clients were hesitant to go to in-person meetings. I mean, they were scared. They didn't want to expose themselves. So in terms of services being available, the services were always there because the health center has never closed down during this entire period. It stayed open and, and staffed to meet clients who wanted to be seen in person or otherwise.
I think in terms of your coordination of the services, could you talk a little bit about how you were able to continue to provide the delivery of medication to the women from Susan's Place after they were relocated and continue to do this, which is really an impressive exercise in management, really?
Well, some of the credit does go to DHS. They did give us money to hire an extra driver now that we were in these hotels. So especially in the beginning, because the pharmacies, to eliminate confusion, we still had everything going to Susan's Place, and we just had a daily delivery schedule to make sure the medication was made. Because we're in 3 hotels. Susan's Place, 200 residents, we're in 3 separate hotels, 1 in the Bronx and 2 in Manhattan. So we kind of got this routine going: deliver medication, deliver mail, deliver food. So we were able to get the clients their medication in a timely manner. If it gets delivered today from the pharmacy, it would get delivered to the hotel on that same day because we have the van going out daily. So that was seamless.
That's been quite an effective management orchestration. I think that kind of leads in for bringing it all the way around to mental health issues and continuity of care. And Dr. Okpala, have you seen any difference or increase in concern and anxiety among the patients that you're seeing during this period of time? Or have things been expressed differently during the televisits?
Okay, I will say we know that a significant number of homeless patients have some sort of mental illness. And among the ones that really have mental illness, most of them have, majority of the homeless with mental illness have severe mental illnesses. So we know there's a need to investigate their mental health their mental health, including their baseline, their worsening psychosis, depression, anxiety, mood disorders. Because I came here, I joined the team during the pandemic. I wouldn't really talk so much about their baseline and like how many patients that were affected, but I know most of the patients that we have, like referred by the primary care provider, like Nora always refer, some patients for me to see. And I've realized that early and adequate treatment of those mental illnesses, the people that present with the mental illness, they're likely to really have a big improvement. And when we identify them early and treat them, that will help them in precautionary measures required in a pandemic like COVID-19, as well as in taking care of their medical condition. So in general, I feel most of the people that I saw during this time, most of them have previous mental illness, they express increased anxiety. They express worsening fear, depression. Some of them have sleepless nights due to what is happening. And some of them are prone to substance use disorder due to the pandemic.
One of the things that I'd be interested in hearing, that you've had the opportunity to provide services for the general assessments at one of the men's shelters that was relocated. And how have the shelter residents that have been having their overall, the comprehensive evaluation done for the 2010E, how have they responded to the telemedicine connectivity? Has that been a positive thing on their end, do you believe, or has there been any feedback about that you've received?
Okay, I think that telemedicine is a big addition to healthcare delivery today and in the future. We all can see how telemedicine skyrocketed during this emergence of COVID-19. I remember when I came here in March, almost all the facilities from under care for the homeless already have the telemedicine capabilities set up. So JAMS is one of those facilities, which is the men's shelter in the Bronx. So I was still able to provide care to them, the people that presented, but just like Simone and Leuth talked about, some of these patients, they kind of withdrawn, they're afraid. So some of them need to be reminded. They need, some of them have, that have good case managers can remind them about talking about their fears to their psych provider, and making it to their appointment. And some of them actually that were moved to the hotel in Manhattan, if they had good device, they were able to log on and still have their visits done through their devices, through their telephone. But if they don't have capable device, they won't be able to log on, because not all of them were able to come back to get set up at the center. So some were withdrawn, some presented, some that had good insight about what they need to be done, or like they need the psych assessment to help them. Good insight helps out.
Overall, there was not a negative interaction with the telemedicine as opposed to a face-to-face encounter. Did anybody say they really wanted to have a face-to-face?
Well, just a couple of people that I saw at at the other shelter in Bushwick. A couple of them wanted face-to-face, and I gave them the opportunity to still come in and meet with me, but with their proper PPE in place. So I was still seeing people, you know, both here at Juniors and Porter Avenue. I was still seeing some people that wouldn't use the telemedicine. Some of them still came in and was seen physically, face-to-face. The majority of the patients that I've been seeing around this time, majority of them have been via telemedicine.
Nora, have you seen an increased need to make primary care referrals during this period of time for anxiety that would have maybe not been the presenting symptom, but part of what was noted in your evaluation?
Oh, absolutely. I pretty aggressively screen for depression in every visit and anxiety in every visit, and especially in the homeless population. You see mental illness, like Dr. Okpala said, with pretty much every patient. I actually want to give a shout out to Dr. Okpala. When she first came in April, I had done a routine televisit with one of our patients in one of the family shelters. And she had mentioned she was severely depressed, hadn't been taking her medication. I was able to get her a same-day televisit appointment with Dr. Okpala, who was able to manage her psychiatric medications, get her proper care. And then she was actually had suicidal ideation and action plans. So she was able to get admitted to the hospital, get the treatment she needed, and then be discharged, and also have follow-up with Dr. Okpala. So that was just a great way that we could get her seen. She actually had moved out of the family shelter, so she didn't even live there. So that was a whole piece to it too. And it was just, it's been great to have the telemedicine and telepsych features expanded for all our patients so they can easily access the psychiatric care that they need.
Thank you. I think it's a good closing the loop. And I guess also, Dr. Okpala, compared to your previous experiences, has this past 6 months, have you done more telemedicine than in your career up until now?
Definitely. The organization that I came from, actually, during the pandemic, they didn't have the capability of having a tele-video visit. So I was just calling my patients and talking over the phone with them, finding out how they're doing, renewing their medications. But I wasn't able to describe their affect, which is a very important part of mental status examination. But when I came here, everything was already there. Everything was set. I was able to see the patient. So, you know, I really enjoyed that process in the sense that I was able to describe the mental status of the patient. So the video teleconference or the tele-video visits, they're very, very practical and very useful to do mental status exam, which is what we need doing psych assessment. So there was a big difference.
Okay. Sort of an open question to the entire group, and we can go and get different perspectives. What would be a recommendation that each of you could make that would improve the system of care going forward? Anybody want to?
I would say just to continue and if it's possible to continue with the telehealth visits. Obviously, that's the future, and it's very convenient not only for the provider but also for the client.
Yeah, thank you, Louis.
Yeah.
Anybody else have any thoughts, recommendations?
Yes. I have the same recommendation in as much as there are barriers to telehealth in different ways, but if the patients are provided with the right devices, like capable telephone device that is capable of having visits via televideo for mental health services, that will be a great thing for the patients. Because I feel telemedicine is here today, it will be here tomorrow, and I don't think it's going away. So even the CMS, they already have a code for billing for telehealth services. So hopefully the patients that have Medicaid and Medicare, I hope they will give them upgraded devices in order to make telehealth possible.
I think you've identified an unfortunate additional inequity in bandwidth in our population. And we've been looking and trying to address this, but that is very, very accurate. One of the things that I don't know that we were as aware of when we went into this was that the number of individuals served by our primary care network did not have access to data plans that could support virtual visits. And yeah, I think that's a critical addition to the overall delivery system. How about could we hear anything in terms of moving forward in the shelter system, Simone? Would you say that there are programmatic or structural changes that would be beneficial or necessary for returning to shelter?
Well, I think there's a couple of things. You talk about telehealth and having the equipment. The other things that as shelter providers we have to do is to ensure that Wi-Fi access is readily available. Clients may not have large data plans, but if they have access to free Wi-Fi in the shelters, it'll help them be able to connect if they have a device. So I think shelter providers, we have to make sure that that's a built-in thing that all residents have access to. I think this is a bigger systematic issue, but I do think COVID testing will have to be looked at sort of like the TB tests when they enter assessment to ensure that, we're not bringing anyone in, introducing any new participant who will expose the others. So I'm not sure if that, right now we have voluntary testing. So I think we will have to look at moving forward. How do we deal with COVID? Not everyone's going to get a vaccine if it becomes available. So I think that's something that the overall system may have to take a look at.
I think that's one of the points that's maybe you could offer some insight on, as well as EJ. When we did the testing initially at Susan's place, there was an overwhelming positive response to being tested. And then that changed dramatically in a 2-month window, where we had over 70% of the Susan's Place residents tested initially, and then back on retesting that was significantly less than that. Do you have any thoughts as to why that may be the case?
I'm sorry, Dr. Bolton. I was busy trying to unmute this and I did not hear the first part of what you said. Would you repeat that, please?
So initially, when we offered COVID testing at Susan's Place, there was a large amount of interest in the shelter residents. Over 70% asked and had testing done. When the testing was offered in the relocation sites, there seems to be significantly less interest. Do you have any thoughts as to why there's maybe less interest in being tested?
I could tell you what I've heard, and then EJ could tell you what her thoughts are. The feedback I've gotten from some residents is, we're already in a room in a hotel by ourselves. Why should we get tested and then get sent to isolation? Many of them had a hesitancy in getting sent to isolation, and they felt that they're in a single hotel room at this point, so they shouldn't have to get sent to isolation. So they just were hesitant to get tested. I'm not sure what you've heard, Ms. EJ.
Well, I've certainly heard that people were concerned about positive results and having to leave. The other thing I think that is important has to do with marketing. For me, communication. It really wasn't, from my perspective, the program, the testing that was available was not really sold as vigorously as it might have been. People might have had some of their fears allayed if there had been more discussion and more outreach to each person. You just sort of had to come upon it, and if your particular case manager mentioned it, but I would say that is something that could be looked into. How do we sell these programs, these opportunities?
Thank you. Any other thoughts from the general perspective before we move to questions that have been submitted? Thank you all very much for your participation. Natalie, do you have a few questions that have been submitted for review?
Yeah, this is great. So we had a couple that were submitted before, and then we've had a couple through the Q&A. So I think I'll go through the Q&A right now, and then we'll go through the ones submitted before. There was one that was, are there any plans to extend COVID testing to more family shelters? That might have been more for Dr. Laraque, but maybe perhaps we have an answer here as well.
I mean, I guess I could address that as we move into the fall and the flu season, the objective is going to be many people will present with ambiguous symptoms that could be cold, flu, or COVID, and that I don't know that we're going to be doing routine screening in the family centers as much as we're going to, of necessity, be doing diagnostic testing to differentiate whether someone has the flu, non-flu viral illness, or another condition. Also, with the children returning to school, many of the programs, if a child has a fever, there's been a blanket recommendation that parents need to have the child evaluated and tested and not return until they have a negative test, so that on that level it's going to be a necessity for us to be able to do testing. There are there's testing modalities that give an upper respiratory panel from the nasopharyngeal swab that can test for multiple potential causes of upper respiratory symptoms that can mimic COVID, as well as including COVID in the panel. Long answer, I guess. Not going to be screening as much as testing for symptomatic individuals in the family shelters coming up in the next few months.
Great. The other one is, do you know the percentage of individuals without phones? I think maybe we can speak about Care for the Homeless specifically, about our population that maybe does not have phones.
Simone, do you know specifically for the Susan's Place shelter population, how many individuals don't have phones at all?
You know, I don't know what the percentage is. I would say most of the clients have phones. However, they may not have minutes, or they may not have smartphones, or they may not have a phone with a data plan. So there's a lot of issues around the phone. Not necessarily do they physically own a phone. So I think that's why the Wi-Fi access is important, and the need for smartphones if they don't have smartphones. But I don't know the percentage, to be honest.
Yeah, I would agree that when we've looked at it, that it's it's having not smartphones that would facilitate the ability to have optimal access and connectivity. And when we had looked at one sheet for, I think, Susan's Place and 52nd Street, we had in the vicinity of about 15 to 20% of the residents had a need for enhanced telephone access. Across the board, the data has shown that that phones are ubiquitous. Everyone has a phone, but a phone is not a phone. necessarily.
Great, thank you. There was one that came in. I'd like to know Care for the Homeless response to residents of the Upper West Side of Manhattan push against hotels providing shelters for persons that are homeless.
Simone, would you like to start on that? I mean, I think that Care for the Homeless has, you know, a 35-year legacy of providing healthcare for homeless populations, and our commitment is and individuals who are experiencing homelessness. The commitment with the relocation has been to really protect and do the best public health initiative for the population that we serve. I don't know exactly what type of a response in terms of an alternative placement or alternative modality for safely relocating shelter populations would have been available, and certainly the hotels in the city of New York provided an excellent resource for our population at a time when they were particularly vulnerable because of congregate care facilities. Simone, do you have any other thoughts on that?
I mean, the only thing I could say is the not in my backyard thing is very common in certain neighborhoods of New York. And the only reason it was known that we were in the neighborhood we were in was because people from the community walked in and knocked and asked. So I don't agree that having shelter residents in certain neighborhoods, in certain hotels have necessarily been negative. Again, obviously it's been painted that way. But I think our residents were just grateful to be safe during a period where, like, the uncertainty, something had to be done, and Department of Homeless Services acted to protect these vulnerable individuals, and they have as much right and deserve to be in whichever neighborhood could provide them the safety they need. So I'm not really sure. I don't really have much else to say other than they have as much right as any other New Yorker to be in whichever neighborhood will provide them the safety they need.
Great, thank you. This is to all the panelists. It says, I know there are a lot of unknowns, but have you started to think about what your work will look like once a COVID vaccine is available?
So I'm gonna say, Nora, why don't you start with that? That would be a good primary care question.
Sure. Well, it also depends, I feel like, on kind of, I know there's been some talks of when the vaccine's available, who will be vaccinated first. So the talk of people with chronic conditions, people who are older. So I work a lot with young adults and children. So I'm not sure if the vaccine evidence is going to be geared towards children as well versus only older adults and people with chronic comorbidities. Those will be the priority first. In terms of general vaccine questions, I feel like it's going to be pretty hopefully positive, but then again, there's a lot of concerns from parents about vaccines already that have decades of evidence behind them. So I hope it's going to be positive, but it's really kind of difficult to say without having the evidence and the clinical trials that we need to first see when the vaccine is actually going to happen and make sure it's safe and effective for everybody first.
I think that's really very, very critical. Some of the concerns that have been voiced on emergency authorization before completion of phase 3 trials. So that's, a lot of medicalese saying that you really want to test a vaccine on 30,000 individuals to see that it does what it's supposed to do and it doesn't cause any other problems. Certainly, if you want to target vulnerable populations with a vaccine, you absolutely want to complete the phase 3 trials to know that the most vulnerable population will be protected and there won't be any additional complication. So I would say for everyone in healthcare that is a major consideration, is that, you know, feeling and reading and knowing that this is something that that all of us, based on our scientific training, we would want to be the first in line to get, so that we should not be giving a vaccine out that is not in the comfort zone for the providers. EJ, do you have any thoughts on what's been in the press about COVID vaccines?
Not the vaccine, yeah. It just so happens that I had several conversations yesterday with friends who either are still in the system or have moved on. And across the board, this is 5 people, each one said that they would not take the vaccine because it was something that was too new, it hadn't been around long enough, and they were concerned about getting sick. You know, it really is not, they feel it's been rushed. I'm sort of on the fence, you know, personally, I'm not sure, but I haven't had the experience of hearing anyone say, oh, yay, this is great, we're going to jump right on it.
Great. Dr. Okpala, do you have any views on the vaccine and how people may, have you been asked any questions from behavioral health clients at all?
Well, not really. But I presume majority of them probably would like to continue remote services.
Okay. If nobody has anything to add, I'm going to move on. We have one. Can you talk about a bit about the relationship? And we have a good amount of telehealth issue or questions. So I'll try to put them in a couple of categories, but here is, can you talk a bit about the relationship between having phone ability and mental health treatment? Could we improve our patient outcomes if we had more people with phone access? I think that's been answered a little bit, but perhaps there's a little bit more to add.
Yeah, Dr. Okpala and Nora, you want to sort of tag team this in terms of health outcomes from mental health access and telephones? I think you've touched on it a few times.
Yeah, I can talk a little bit about it because I refer a lot of people to Dr. Okpala and other telepsych services. But baseline, one of the hardest things for people with mental illness is to, especially with people with depression, people with anxiety, is literally to get to their appointment, right? That's baseline. Like, yes, I can refer you to a psychiatrist, but if you have to travel that 25 minutes on the train with your 4 kids under the age of 8 because they don't have school, they're all remote learning, to get to that psychiatry appointment, and you're already depressed and you're already anxious and you're already worried about COVID, that's extremely difficult, right? It's terrible, like that they already have all this baseline anxiety about leaving the house versus all this other thing. So I feel like telepsychiatry and telehealth really opens up that gate to help those individuals that already have a lot of anxiety and depression actually get to their appointment, because that's one of the biggest barriers of connecting people with mental health services, like physically having them go to the appointment. So I think that with the ability to do it from a Zoom on their tablet in their room, in a safe space where they have their children next to them and they don't have to arrange childcare, they don't have to arrange transport, they don't have to pay that $5 to get that Metro card. I think it's huge.
Thank you. And Dr. Okpala?
Yeah, I feel the same way. I feel most of them will be connected to services, to mental health services, if it continues to be remote, because the trouble, you know, trying to get to a distance to get into the clinic. Most people would like to have their services rendered at home if they have that option.
Thank you.
Great, thank you. I have another one that says, if mental health issues are so widespread, is it necessary to increase public information on self-care?
Dr. Okpala.
Yeah, I would say yes. you know, mental health issue comes, it comes with stigma. So a lot of people don't want to be stigmatized. So that's one thing, one area we need to really educate people. Some people don't want to go to the clinic because, you know, they don't want to be told they have this kind of disorder, you know. So the more education we put out there for the public to understand that mental health issues is regarded as somebody that have diabetes, a medical condition. So you still need to take care of it. So the more people we educate in terms of mental health, the better for everyone. So people that are affected can, you know, seek help as needed without being stigmatized. Yes.
Thank you. The next one is, how do patients without access to technology get telehealth visits, or are they not getting telehealth visits?
So I sort of take that. We've developed a hybrid model with Care for the Homeless so that it really overcomes that barrier. And the hybrid being that individuals who say don't have a tablet and access to a PC or a smartphone with a plan are able to come into the health center and be connected, you know, as though you were going to have an on-site visit. You'll come in and be in an exam room and be connected. And that's been the big benefit of the hybrid model, is that it overcame that barrier for individuals who were not otherwise be able to have access.
Great. Another one is, how do you evaluate the effectiveness of virtual practice with the homeless population?
So I can, does anybody have any comments that they'd like to offer on that? So again, in terms of what we've done, we've looked at a number of our quality indicators that we monitor routinely to see what the fluctuations are. You look at people, you know, staying in the system of care, no-show rates, and very fortunately, we're able to say that we've had, in some areas, significant improvements since we've initiated the telehealth initiative, and where we have had not improvements because patients are not coming in to have blood pressure checked, so that an improvement in overall blood pressure control was not documented. The fluctuations that we've seen have been minimal, and also evaluating patient satisfaction and patient experience with what their access has been. So during this period of time, we've done a 10% satisfaction poll on individuals who've experienced telemedicine or telephone medicine, and gotten very positive feedback and constructive input. Generally, I think that the telephone access is seen as beneficial. The most positive feedback is when it's from the televisits. And we continue to need to do this type and more evaluation going forward.
Thank you. I think this will be our last question, and it wraps it up pretty well. It's what are the 3 most critical service gaps facing persons and families who are experiencing homelessness today?
Does anybody have a preference on taking that? Simone, you want to give that one a try, maybe?
Service gaps. I think, what we're providing, we provide pretty comprehensive services. So maybe because I'm working at Care for the Homeless and I'm so lucky to have that, I can't think of what it might be. If I'm asked, what are the biggest challenges in homelessness, I'm always going to say affordable housing. So I'm not really sure. Finding housing for our clients, not enough supportive housing.
Well,
discriminatory.
housing is healthcare. We all subscribe.
There you go.
I agree with
So
that.
that brings it around.
Yeah, so I think dental services have always been a challenge, and during COVID, certainly the ability to give the services that we are generally able to provide has been limited. We're getting back into primary preventive and interventional dentistry now, and some of the consultative podiatry and optometry are also services that that we hope to be able to expand access to going forward.
Great, thank you. That ends our Q&A. For anybody that did not have their questions answered, we'll make sure in our follow-up email to send the answers to those to everyone, okay? And that's it for Q&A.
So I'd really like to take this opportunity to thank everyone on the panel for your service, your commitment, for being on the front lines and continuing to be there. Thank you, EJ, for sharing your perspective, which is the perspective we need. We need to know that what we're doing is constructive and helpful and accessible. And Simone, for you and your team, thank you very much for everything you've done to help the continuity of care that that Care for the Homeless has been able to provide during the past 6 months. There will be a quick survey at the end of at the webinar for all participants. We really hope that everyone will take 1 minute and answer the questions and let us know how this gave you new information and what we could do going forward. Thank you for participating, and have a good day. Stay safe.